So I'm here to briefly demystify what you might expect at your first office visit following your spontaneous dissection. And it's precisely because many of you have probably not had a reason to see a cardiologist before. And this is really an opportunity for you to have to demystify the experience and understand what you might be doing in the outpatient setting. So the first thing that I really focus my visits on is to really make sure that patients understand this specific disease. What I find is that a lot of times patients have had this really unexpected experience and then have also encountered the understanding that SCAD is a relatively rare type of heart attack and a feeling like they don't know what happened and that maybe their care team around them in the hospital may also not have had answers to all of their questions. And so this is really my opportunity to try and make sure that you understand what happened during your heart attack, which also includes ensuring that the diagnosis is accurate. So a lot of the diagnostic tools that we use to diagnose heart attack was really developed for the traditional atherosclerotic or plaque-mediated heart attack. And so it can be a lot harder to diagnose SCAD and to be confident about that diagnosis. So a lot of times where there are less clear cases based on the diagnostic information available at that time, we do have the opportunity at Mass General Brigham to have a large group of doctors review cases so that we can really make sure that we have the right diagnosis. And the reason that is important is really because the treatment of SCAD is very different from that of atherosclerotic disease. And so what I really try to do is go through what the disease is, which you guys have heard about today, but the difference between a spontaneous dissection and a traditional atherosclerotic heart attack is really that it's because of development of a bruise or hematoma in the blood vessel wall that leads to narrowing of that blood vessel. And with time and medicine, most of those dissections heal. And so in the clinic, I also like to think holistically about people's care and think about all the contributors and associated conditions that we know come along with SCAD. So as you've probably heard, one of the most common things that we find is that the blood vessels of the heart are really not unique to the heart. They're the blood vessels you have in the rest of your body. So that's why we go looking at those blood vessels, and we advocate for patients to have extra coronary CT scans. That's a CT of the head, neck, abdomen, and pelvis. MRA can also be used, or a special type of MRI, although at our center we favor CTs. And really for that, we're looking at those extra blood vessels outside the heart to make sure that we don't see any other areas for which you may benefit from seeing a vascular specialist. And oftentimes the most common finding that we see is something called fibromuscular dysplasia, which is, again, something that we can pick up by imaging. In a more minority of patients, we'll see an inherited arteriopathy or specific connective tissue disorder that may be associated with susceptibility genes, but really there is not a single SCAD gene. And really this is a complex genetic condition that we think and are still learning about. That's where the GVASC study, I think, will shed a lot of light on this disease process for us. We know that a commonality between a traditional heart attack and spontaneous dissection is high blood pressure. So if you think very just simply about it, having blood vessels that may be more prone to dissections or aneurysms, having lower blood pressure that those blood vessels see is going to place you in a better spot for making sure that we reduce your risk of having another dissection event. You heard all about pregnancy in our last session, and that's why it's so important to be able to have those discussions about your reproductive goals and also contraception at your cardiology visit. And then we know that, as we heard, that SCAD can be a very stressful experience, and taking care of your emotional health and your mental health after a spontaneous dissection is really important. Here's what we know about chronic medical therapy. So even though we know that most SCAD is successfully treated through medicines, there's still a lot that we are learning. But right now, we think that beta blockers which are a certain type of medication. There are a lot of beta blockers out there, are the medicines that we think are associated with the highest benefit. So I try my best to get my patients on a beta blocker if they can tolerate it. One thing I would say is that you get brownie points for being on that beta blocker, but there's no one beta blocker that seems to be better than another. And there's not really, you have to get to this target dose of the beta blocker. So I really work with my patients to see what is a beta blocker that they can tolerate. We use a baby aspirin as well after spontaneous dissection. And then we really look to managing other associated cardiovascular conditions, which can include the use of anti-angiotensin medicines for people that continue to have symptoms. And then, as we talked about, managing other sequelae, which can include medicines to treat low heart function, and also medications when needed to help with the treatment of associated anxiety and depression. Things that we don't necessarily reach for is people that have not been treated with a stent. There is really an uncertain role for dual antiplatelet therapy at this time, although it's really something that we need more data regarding. And then we don't often use blood thinners unless there's another reason to think about that. And then again, because a spontaneous dissection occurs because of a completely different mechanism of disease as compared to an atherosclerotic heart attack, we don't use statins necessarily for SCAD. Although, again, if patients have high cholesterol levels, we'll still use statins if we would have used them anyway. But it's not necessarily to prevent recurrent SCAD. In the interest of time, I'm just going to show this as most recent data that make us sort of question and realize that we really have to learn a little bit more about antiplatelet medications after SCAD. And then another thing I want to talk about is that chest pain is very common after SCAD. I think it's the most frustrating symptom that continues to linger. And it's frustrating as well because there's so many different potential causes of chest pain. So in the clinic setting, when someone is not having a heart attack, a lot of times delving into the details of exactly what that chest pain is can really help us distinguish whether or not it's still recovery from the SCAD. Sometimes the healing blood vessel can result in chest pain. Sometimes people can have associated chest pain syndromes like microvascular dysfunction or coronary spasm that occur very commonly after SCAD. We'll be hearing a little bit more of that in a minute. And then unfortunately, we know that there is a large proportion of patients that continue to experience what we call non-ischemic chest pain, where the blood vessel looks good, the blood flow looks good, and that chest pain still persists. This is something that is very challenging because we don't have a clear-cut silver bullet to treat that, but that's something that is certainly a topic of research and interest among those of us in this field. And then I wanted to talk a little bit about exercise as well. So Catherine Leon mentioned that cardiac rehab is so important. We do know that the blood vessel heals along the time course of 4 to 12 weeks. So especially during that time period, as Catherine Leon mentioned, resting is really so important, really listening to your body so that you can make sure that your blood vessel really has the opportunity to heal as well as your body. But I think one of the greatest disservices we can do is to make people nervous about exercising, because we know that there are so many health benefits to exercise that all of us can benefit from. So what we do recommend, as Catherine Leon mentioned, is once you have recovered from that spontaneous dissection, you feel ready to, usually along the lines of somewhere between 4 to 12 weeks, when the blood vessel is more healed, engaging in cardiac rehab. And the reason for this is even if you were, and sometimes especially if you were a highly active individual before your spontaneous dissection, cardiac rehab can make you feel more comfortable with re-engagement and exercise in a monitored setting. And the goal would be that at the end of that experience, that you really feel comfortable understanding what you can do with your body at that period of time. And what we really encourage people to do is to engage for the long term in more moderate aerobic exercise. As you can see here in the red down here, what we counsel against is really repetitive heavy lifting. So something like this, where you have to engage in Valsalva or straining of your entire body to lift something. And it's really because of the impact on blood pressure. So that heavy repetitive lifting causes spikes in blood pressure. And as we mentioned, those blood vessels that are prone to dissection are better served with lower blood pressure. As Catherine Leanne also mentioned, and many others as well, data from the iSCAD Registry have really shown and opened our eyes to the fact that this is a very traumatic experience for many patients. So if that is you, you are not alone. About 35% of patients in iSCAD met diagnostic probability for SCAD-induced PTSD in their lifetime, and 6% met that criteria just in the past month of them being asked about it in iSCAD. And unfortunately, the minority of patients really receive the treatment that they need. So it's really important if you identify with that, for you to talk to your cardiologist or your primary care doctor about being connected to the care that you really deserve to help you and your whole body recover from this experience. In terms of the risk of recurrence, this is something that I think is top of mind of patients when they come to see me in the office setting. I've shown you a couple of recent data in terms of the recurrence rate here on this table. We do know that recurrence rates can really drastically differ depending on how a study was conducted in a registry. There are some biases in terms of how registries are collected. Oftentimes they are in the office setting, so there are differences in terms of who even gets into a registry. And that we do know that there are patients that can experience spontaneous dissections many years out from their initial event. But what I really want to emphasize is the dissection recurrence rate is still much lower than the likelihood of never experiencing another dissection. And I say that to echo what Catherine Leanne again said, that it's important to reduce the risk of a recurrent dissection with the tools that we know that we have, but really that for the majority of patients, a recurrence is unlikely. And it's really important, therefore, to make sure that you are able to live your life after recovery. I also want to emphasize there's still a lot that we don't understand about spontaneous dissection. And I think about it in the perspective of we have known about atherosclerotic heart attacks for decades and decades, and we're still learning about atherosclerotic heart attacks and how to best manage it. Our timescale of understanding SCAD is really much narrower. So there's still a lot that we are learning, a lot that we don't know, and we really appreciate all of you who are contributing to the efforts to advance our knowledge in this field, because I do think that with time we'll be able to offer patients a lot more than we can today. And I think the future is really bright in that respect. So here are my conclusions, but I really want to be able to make sure that we have time for all your questions at the end. I'm happy to answer any of those. And thank you so much for having me today.